Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I am Professor Adam Ahmad Adam. I am going to give you a brief account about systemic mycosis before starting the lecture. Systemic mycosis are primarily lung mycosis. Some of them, in their severest form, disseminate to different parts of the body. The fungi causing systemic mycosis are opportunistic pathogens. They affect people with defective immunity, such as immunosuppression, local organ disease, hypersensitivity to fungal antigens. People with normal immunity commonly abort the infection, or they may have mild self-limiting disease. I am going to give you a brief comprehensive lecture for each topic. This lecture is composed of two topics: Aspergillosis and automycosis. We start with Aspergillosis, which is a mycosis caused by Aspergillus species. These fungi are molds. They commonly infect the lungs. The Aspergillus species are found widely spread in nature, especially oxygen-rich environments, and also they are common contaminants of starchy foods. We are going to talk in a minute about this point. The Aspergillus species are Aspergillus fumigatus. This is the commonest cause of lung mycosis in general, and also the commonest cause of pulmonary aspergillosis. Aspergillus niger, it causes aspergillosis, and moreover, it causes automycosis. We're going to talk about automycosis in this lecture. Aspergillus nidulans, it causes aspergillosis in addition to eumycetoma. Aspergillus flavus and Aspergillus parasiticus, they cause aspergillosis, and they grow in cereals and groundnut, producing a toxin known as aflatoxin, which is a liver carcinogen. So people who used to eat such infected food for a long time are predisposed to develop hepatocellular carcinoma. Aspergillus terreus, it causes aspergillosis. The infection takes place by inhalation of spores, and we have to mention here that the disease is not contagious. People with normal immunity abort the infection, but people with defective immunity are most likely to get the disease. The clinical types of aspergillosis: allergic bronchopulmonary aspergillosis. This is in hypersensitive people to Aspergillus species. It is type 1 hypersensitivity reaction leading to a release of vasoactive amines that act on the smooth muscles of the respiratory bronchioles, leading to their constriction. So you see here, compare the constricted respiratory bronchiole on your right hand side to the normal one on your left hand side. Aspergilloma, there will be an aspergillus growth in a pre-existing cavity taking its shape. The cavity may be in the lung, and the disease is known as pulmonary aspergilloma. You see here, the arrows are pointing to an opacity in the lung. This is pulmonary aspergilloma. The cavity may be due to tuberculosis, sarcoidosis, or other diseases. The lesion may be symptomatic or maybe asymptomatic, just detected by accidental X-ray. Also, aspergilloma can be found outside the lung, known as extrapulmonary aspergilloma. The common site, here you see, this is aspergilloma in the maxillary sinus, the nasal sinuses. So one or more of the nasal sinuses can be the site of infection. Chronic necrotizing pulmonary aspergillosis. To start with, there will be lung disease that leads to necrosis of lung tissues, and then the infecting aspergillus will settle in this necrotic tissue and it grows. You see, the arrows are pointing to the dark necrotic lung tissues. Invasive aspergillosis, and this is quite common in those who are severely immunosuppressed, and there will be dissemination to all over the body. Diagnosis, clinical, depending on the presentation, and then laboratory investigation by taking a specimen and doing culture in subroad medium. Treatment, it depends on the clinical type. Allergic pulmonary or allergic bronchopulmonary aspergillosis, this is hypersensitive reaction, can be treated by corticosteroids. Aspergilloma, uh, it can be removed if it is expanding, symptomatic, or pressing on vital signs. Otherwise, it can be just followed up. If treated surgically, surgical removal is curative. So it is observed if it is not expanding or causing symptoms or pressing on vital sites. If it is doing any one of these, it can be surgically removed. Chronic necrotizing pulmonary aspergillosis, you give amphotericin B, and then you can remove the dead tissue surgically if the condition of the patient can withstand surgery. Invasive aspergillosis, amphotericin B. Then we come to the second topic, which is automycosis, and this is mycosis of the external air canal caused by Aspergillus niger. More than 80% of cases are due to Aspergillus niger, causing black air discharge. Then Candida albicans and Trichophyton species. The infection takes place by manual introduction of the pathogen into air canal, and there may be superadded bacterial infection, secondary bacterial infection. The patient here will experience air pain, air fullness, hearing loss, and air discharge. Diagnosis, clinical. In case of black discharge, diagnosis is clinical straight away. It is due to Aspergillus niger. Also, to do laboratory diagnosis, you can take a swab from the discharge and you culture it in subroad medium to reach the etiological agent. Treatment, the first thing is to examine the tympanic membrane If it is intact, you can do ear toileting and you give antifungal drug drops. If it is perforated or ruptured, you give systemic antifungal drugs. By this, the lecture is over. I hope that it is understandable and I wish you all the best.